All right. Well, let's get rocking and rolling. We may have some other individuals that come on in the room after the fact. Hello and welcome. You are in the right place. I just know you are, even if you stumbled here by accident. This is the CFHA Collaborative Family Healthcare Association's Collaborative Care Special Interest Group, or SIG as we call it for short. So, welcome to the CoCM SIG, where we talk about all things collaborative care adjacent, what's going well, what's not, policy, advocacy, implementation, finance, all the things. This is your group, this is your place. So we welcome you to the group today. We meet the first Wednesdays of every month virtually at this time, 2 p.m. Well, Eastern time for me. So it depends on where you are. I know it's 11 a.m. for my West Coast colleagues, and so 10 a.m. Central Time. Yes, do I have that right? Maybe, no, 1 p.m. Central Time. So wherever you are, it happens this same time, first Wednesdays of every month. Um, I am Monica Harrison, licensed clinical social worker by trade, lover of all things integrated care. I work for the University of Washington, and I am one of your leadership team for the Collaborative Care SIG. We are missing today Laura Sadari. She is out today, but will join us the next time. She also serves as a part of one of the medical directors for CFHA. And then Ben, who will introduce himself.
Hi, just quickly, I'm a mental health provider for about 30 years. That's where the gray hair comes from. And I've been doing collaborative care for like 5 years, worked in health tech. I think most people know, but I just took a new position at Janus Healthcare Partners as a VP of Clinical Success and Program Development. And we are headlong into Michigan and Florida and also value-based care. Back to you, Monica.
Awesome sauce. So Ben, Laura, and I make up your leadership team this year for the CFHA Collaborative Care SIG. So if there are topic areas that you would like to see addressed during this time or discuss, please reach out to any one of us. We have monthly leadership meetings as a team to talk about and plan for the upcoming year and post some things for the team that will take over the following year. So if there are things that you are interested in hearing about or having us discuss during our time together, we welcome your suggestions and input. Ben, were you going to say something?
Yeah, just we have another leadership person here too. So why don't we just introduce Jennifer real quick?
Oh, yeah, absolutely. So those of you who are watching, maybe have your screen on, you will see Jennifer Thomas, who I'll let her introduce herself in her role with CFHA. She is a part of CFHA's leadership team. Jen?
Yeah. Hi, everyone. I'm the co-pilot with Laura. So we're both the co-medical directors for CFHA and just working on boosting our presence with all of the medical trained folks in the world, nurses, NPs, PAs, physicians, to have more medical representation on our integrated care teams. So great to be here today.
Thanks so much, Jen. We have who you probably won't see because she probably won't come on camera, but maybe she might, Hannah, who is with CFHA, offering our support, administrative support for today, and a great colleague to know. Hi, Hannah.
Hi everyone. I am off camera today, but let me know if you need anything.
Absolutely. Thank you so much. She keeps things rocking and rolling in the background for us all the time. Super appreciative. So thank you, Hannah. Um, Lots of things for CFHA, but I want to jump into our topic for today so that we have time for our speakers to speak and for you all to be able to ask your questions that you might have. And then hopefully, maybe we have that transition time. Those of you who are just hopping on, I just talked about we don't always get that transition time in between meetings to take care of ourselves and just the importance of that. So I want to go ahead and hop into our topic for today. Hopefully, many of you saw the message that went out about the meeting for today, where we're kind of short paraphrase going to be talking just about different types of technologies to incorporate, right, in your integrated care, whether you're doing collaborative care, thinking about doing collaborative care, doing PCBH or other forms of integrated care, we know there's a whole continuum of services that a lot of you are offering to your patients and providing a service to your patient population, to your clinics. Some of you are in more administrative roles, completely fine. So we have two speakers for today that I will lightly introduce. So Ethan and Caitlin, don't like jump on me now because I'm gonna let you all introduce yourselves more thoroughly. But we have two speakers for today. Ethan, who is joining us now. Ethan, you will tell me if I pronounce it wrong. I know the emmacare one, but the other one, is it RemoteFocus?
RemoteFocus.
Okay,
Yeah.
I got it right. I wrote myself a note over here to the side. When you have double screens, you could do that kind of stuff. So I wrote myself a note over here to the side. So we have Ethan, who's joining us today to talk to us about AI, gamification technology, things of that nature, and kind of what he is doing. And then we also have Caitlin, who's joining us from Rejoyn. So Caitlin will be talking to us just around personalized digital therapeutics and how we can maybe start to think about that, incorporating that, having that of what we offer for our patient population. So I'm going to let Ethan go first, and then we'll follow up with Caitlin. We will have time at the end for your questions, so please hold those or put them in the chat if you don't want to lose them. If you're like me, like I just need to get it out so I know I asked it. That's fine too. So either hold those towards the end or put them in the chat and we will get to those. Ethan, take it
Perfect.
away.
Thank you so much. I'm going to share my screen, if that's okay.
Yeah, absolutely.
Okay.
All right, it is coming. Let's see. It says you've started sharing, but we don't see anything. There it goes. We see your backdrop, which looks gorgeous. And now we see RemoteFocus.
I'm just going to flip this over, though, just so I could stare at you all. Okay. Okay, perfect. So nice to meet you all. Thank you so much for having me. Thank you for this opportunity. As Monica mentioned, my name is Ethan Baraf from RemoteFocus. Just by way of background, I've been with RemoteFocus really since the onset for 4 years now. Prior to joining RemoteFocus, I was with a behavioral health organization. That's really where my experience in the medical and behavioral health field started. I was running their care management program we're located in New York. I'm located in New York, and we were providing health home services. I was doing that for 6 years until I joined RemoteFocus, and very happy and excited to be where we are today. So at RemoteFocus, sorry, just switching this over. So at RemoteFocus, we've really built a diverse and experienced clinical team designed to meet patients where they are, clinically, culturally, and emotionally, that with the idea of delivering truly coordinated whole person care. We have a whole team of physicians, nurse practitioners, PAs, nurses, case managers, working with Medicare beneficiaries, assisting them with their multitude of medical needs, focusing on their chronic conditions. Our goal is to keep patients healthy, keep patients out of the hospital, and keep patients out of the emergency room. We really want to keep patients in their comfort zone at home as much as possible. We've, like I said earlier, we've been doing this now for 4 years. We have over 6,000 active patients in the New York, slightly in New Jersey. We just started tapping into the New Jersey areas, and as well as Florida. We just started expanding into Florida. So we're really mostly in New York, but building into those other areas as well. Last year alone, we serviced over 10,000 patients throughout the 12 months. We have over 55 providers. Most of those are home care agencies, physician groups referring to us to assist them with a multitude of services. And we assisted patients in procuring over 19,000 DME orders last year alone. So what does RemoteFocus do? So like I mentioned, our goal is to keep the patients healthy and at home. We're supporting patients and families in navigating those healthcare challenges and closing their care gaps, and strengthening the patient's circle of care, collaborating with all their involved providers. The example that I like to use is, like I mentioned, we're working with the Medicare beneficiaries. Many of them are more from the geriatric population, certain individuals with multiple chronic conditions, and a lot on their plate. Some of them have a great support system, some of them don't. And even if they are serviced by their PCP, they're seeing their PCP regularly, when they go and visit that PCP, there's a lot on their plate when they leave that appointment. Even getting there is difficult for many of these members, but walking out, having a multitude of chronic conditions, walking out of that appointment could be very overwhelming. They're given a referral to a specialist. They need to go for imaging for certain conditions. They have lab work to follow up on. They have prescriptions, which is great because it could be e-prescribed, but at the same time, now you have to make sure that they're getting it and delivered. They need to make sure that their follow-up visits, there's so much on their plate, there's so much needs to be done. So RemoteFocus really takes that burden off the family member, off the patient, and really handles the case management services to assist in all those different items and all those different areas. We're providing a multitude of services in order to make sure that that's all happening. We are providing remote patient monitoring. We have a team of nurse case managers who are providing chronic care management. Whether the patient has the PCP or not, there are times where they don't want to connect with their PCP, they don't want to reach out to, or they're having trouble reaching out to their PCP. We have our own physician group, which is that group of nurse practitioners and PAs who can assist with live telemedicine appointments. We'll make those referrals to specialists, able to e-prescribe as well, and make sure it's delivered to the patient's home, and then assist with the collaboration and coordination of all those specialty appointments as well. The goal of RemoteFocus, like I mentioned, is to keep patients healthy and at home. And the true way to make that happen is by closing those gaps in care. Our case managers are performing that by scheduling and coordinating medical appointments, arranging in-home imaging and lab services. There's nothing worse than sitting in a lab waiting room for hours at a time. And again, we're dealing with them so many times elderly individuals that it's not so easy to travel and sit there and wait for lab when you can really draw those samples at home and obtain those and make it easier for them as much as possible. So we're arranging all of that. We're supporting them with those DME items, like I mentioned earlier. That's probably the most common usage of our services. The patients when they're enrolled in our program, our clinicians are reviewing all their medical needs. If there's an abnormality of gait, we're handling all those DME equipment needs. We're coordinating the transportation to and from appointments, connecting patients to social and community support resources. And we do have our own proprietary software, which Monica mentioned earlier, which is called emmacare. And that is what we're utilizing for our patients and our patient care. Patients are given a user-friendly mobile app, whether it's them or their caregiver, and they're provided with real-time access to their clinical data via our patient portal. So who is an ideal referral for RemoteFocus? I italicized the first three because these are really the key points. It is specific for Medicare Part B beneficiaries, patients with frequent hospital emergency department visits, and individuals managing two or more chronic conditions. And that second point is a very important point. While many patients may have multitude of chronic conditions, managing two or more regularly, if they're managing on their own and they're handling all their needs appropriately, they may not be the best fit for our services. We're really looking to focus on those who can really benefit from that extra level of care. Those patients who are homebound, that have mobility limitations, patients with who are high-risk individuals requiring closer monitoring, patients with limited or no family support, individuals with cognitive or behavioral health complexities, patients affected by social determinants of health. We really built out our social service referral group. We've connected to a number of groups that are focusing on the social service needs of patients, and we've been able to assist them with those items. And then again, we're offering remote patient monitoring, so those patients who need regular vital sign monitoring would also be a good fit. So just continue with that remote monitoring idea. Our software picks up and is utilized as a remote patient monitoring system. So we're able to provide RPM by offering them Bluetooth and cellular enabled blood pressure monitors, pulse oximeters, scales, and thermometers. And the system is set up so that our team is alerted in real time of any abnormal readings, so we could follow up with them appropriately. All vitals are visible through the patient portal, so that we can also share access to their caregivers, with their family members, and even with their PCP if they wish. The system is set up really to encourage engagement. Like, that's really the goal. If you're looking to really properly take care of a member, take care of a patient, you need to make sure that they're engaged in the most efficient way possible. So our emmacare platform has allowed us to really stay in touch with the patient in a multitude of ways. We have two-way text messaging with the care team. We send out automated reminders for their vitals, for their appointments, and their medications. We have on-demand virtual urgent care access. Literally, with the click of a button, they can, they log into their portal. Within one, I think actually two, there's a security question that they need to enter. After that, there's one other button that will allow them to select virtual urgent care access if anything ever arises. And then they also have RemoteFocus tech support access directly through the emmacare app as well. The portal is set up to provide the full history. All those vital trends and measurements are stored in the portal. So if they're going to their appointment with their PCP, they can go and show their PCP that full history so that they can review it as well. There's a personalized care plan that's able to be reviewed by the patient at any time. We are also utilizing educational materials through emmacare. So we're sending patients diabetic, for example, we're sending them nutritional pointers. We're sending them different items to remind them about their conditions. And we are also utilizing through emmacare e-prompts, interactive surveys, and wellness questionnaires. We're sending them different surveys to make sure that they're happy, they're comfortable, and they're getting the care that they deserve. So AI is the hot topic. AI is the big, the topic that everyone's focused on right now, and we're starting to utilize it in emmacare as well. This is a picture of our sandbox system. So it's not an actual patient, but it does look very similar to this, where we're able to actually analyze the trends in the patient's care. If there's a specific trend in their vitals and their measurements, we're able to analyze that and act on that. If there's any potential gaps in care, we're able to focus on that as well. So that's already been released. The three other items here are actually being piloted currently, which is the care plan optimization. Our AI system that we're using right now allows us to take the clinical notes that our clinicians put together and then run it through our AI system to then create personalized, goal-driven care plans for the patients. It really allows us to provide a standard of care across the board, and it shoots out suggested care plans, interventions that the clinician and the nurse case managers can work on and really keep the patients at the appropriate within the appropriate care level. We're also utilizing predictive analytics, using the measurements, using the vitals, and anticipating risk events. Obviously, trying to be as proactive as possible. We also have AI flag outliers. If a patient misses their follow-up appointments, misses their measurements, misses their readings, we're able to flag that, deal with it, address it, reach out to the patient as quickly as possible. While that's all great in the sense of patient care and medical care, it's really not the full picture in what our patients need. And it took us, we realized this early on, but it took us some time to pinpoint how to really impact the patient's care. And I guess that's really what brings me to this conversation and this group today. We built a nice foundation focusing on that patient-centered medical care by utilizing remote monitoring, by utilizing chronic care management. But what we saw over time was that patients really did not improve their health outcomes with emotional behavioral health concerns. What we saw was patients who were struggling with anxiety, depression, or cognitive decline weren't following their care plans. We had all the pieces in place. We conducted an assessment. We monitored them. We gave them the tools. We engaged them. We reached out to them. But if a patient was unfortunately suffering from anxiety and depression and they needed to attend an appointment with a specialist, or they needed to follow a specific a specific diet, but they were never leaving their bed and they were refusing to eat, we really weren't focusing on the full, the proper care of that patient. We saw chronic conditions worsen over time due to behavioral health symptoms. Isolation, grief, and caregiver burnout were definitely impacting outcomes. So it was very clear that medical care alone was not enough. So to close this gap, we began integrating behavioral health services and the collaborative care model, which we're just starting to get off the ground currently. We've incorporated behavioral health screenings into the care of the patient. We've coordinated care with behavioral health professionals directly. Our care plans are now aligned with both medical and emotional needs. For a while, we were really focusing on the specific medical care of that patient. Now it's also incorporating those behavioral health, emotional needs of the patient. Medicare is obviously supporting those services, so there's really no other additional burden on the patient. There's nothing else, no other program that we need to refer them out to. We could really handle this in-house internally. And now we're providing more of a complete support for vulnerable and high-risk population. And again, taking us back to our platform and our system, by utilizing emmacare and the tools that we've created, we're able to send them digital surveys, EPROMs to assess mental and emotional health. We're able to track behavioral health concerns in real time. We can keep patients connected with automated check-ins. Just a simple survey, simple one-question questionnaire. How are you feeling today? Something as simple as that, and just having them answer that on a scale of 1 to 5. How are you feeling? It makes the engagement very, very simple, very efficient, and easy to follow up on within our own abilities. We're reinforcing ongoing clinical support between live interactions. We've also built our collaborative care registry in emmacare as well, which allows us to centralize the patient data, progress notes, and our care plans, allows us to be within compliance for the program, and enables efficient case management and timely follow-up. And that's me. So thank you so much for your time, for this opportunity, and we'd love to hear if there's any questions.
Gotcha. So Ethan, don't go anywhere because we're going to do some questions at the end now. So,
Of course.
yeah, all right. Thank you,
Let me
Ethan.
stop sharing 1 second. There you go.
All right. I'm going to transition us over to Caitlin.
Awesome. Thank you so much. Let me share my screen here. Let's see. Okay. Can y'all see my screen?
Yes, we can.
Awesome. Cool. Well, thank you again, everyone, so much for having me. I'm Caitlin Stamatis. I am on the medical strategy team at Otsuka, and super excited to chat more today about digital therapeutics and how they hopefully can fit into the treatment landscape for depression. So just COI up front, I'm an employee of Otsuka, a pharmaceutical company, and just in terms of my background, so I'm a clinical psychologist by training. I do have a small private practice, but really my career has been in health tech. So I've done research, clinical product development at a range of different companies, from Google to smaller biotech companies to now pharma. And here at Otsuka, I work on a digital therapeutic called Rejoyn, which I'll share more about today. And but kind of more generally, really my goal today is to talk about what are digital therapeutics, demystify them a little bit relative to other types of health technology. And then second, to talk more specifically about Rejoyn and give you all a sense of sort of the clinical research and data that lead to FDA authorization of a tool like this. And in the case of Rejoyn, for it to be authorized as a prescription digital therapeutic for the adjunctive treatment of MDD symptoms. So getting into some of that background, right? So this is, I'm sure, not news to this group, but not all digital tools are created equal. It's a very, I think, big, confusing, messy landscape that that I think a lot of us as providers are trying to navigate, right? Because we have different different kind of vertical like categories of these digital tools. So, of course, there are, on the one hand, health and wellness apps. This is everything from a meditation app to relaxing sleep sounds, right? Or med reminders, but just tools that promote general well-being, healthy living. There's no regulatory oversight over these tools, and some have incredible clinical evidence to back them up, and others don't, right? So there's no required clinical evidence component there. And then we get into more of the patient monitoring and digital therapeutic side of things. So on the patient monitoring side, these are tools that are used to evaluate specific health data, right? That could be a mood diary, or like I wear an Aura ring, right? A sleep tracker. Oftentimes there is FDA review of these types of tools, and clinical evidence is required, right? Because we're collecting data that's supposed to map onto these clinical features. And then digital therapeutics. So these are treatments. They deliver software-based interventions to specifically treat or alleviate a disease, condition, disorder, injury. And examples of that could be a CBT app for insomnia, or a video game-based treatment for ADHD, right? So lots of different categories. And zooming in a little bit more to digital therapeutics. So in order for something to be a digital therapeutic, they have to be scrutinized pretty heavily by FDA, right? So typically a phase 3 clinical trial, similar to what would be done in a trial of a new drug, has to be submitted showing that the digital therapeutic is effective in the population of interest, that it's safe, and there are lots of types of digital therapeutics. So some can be used independently, some are non-prescription, some are prescription, some are used in combination with medications or other therapies. But in general, and kind of what drew me to this field in the first place, is the idea of scaling access to quality care. And I think about it with, I'm cognitive behaviorally trained in terms of the type of therapy I provide. There are many cognitive, right? Like, we have no idea if people who say they're doing CBT, I could say I'm doing CBT and someone could come to me for that, and I'm doing anything but that, right? Or doing something totally different. There's really no oversight regulation into psychotherapy and how it's delivered. Obviously, we have quality metrics and measurement-based care, but I think the idea of being able to package those evidence-based mechanisms into a digital tool and scale access to that is something that I get really excited about when I think about the promise of digital and digital therapeutics. And so I will share a little bit about a clinical trial that our company led on our digital therapeutic Rejoyn, just to give you a sense of how these types of digital tools come to be prescriptions that that folks in the healthcare system can order for their patients, and the type of evidence that leads us here. So this was a trial looking at the effectiveness and safety of Rejoyn in adults with major depressive disorder. And so backing up, I'll tell you finally what Rejoyn is. So Rejoyn, this is what's on our label, right? So again, like the same way you would have to look if you look at a drug label. So we are an FDA authorized prescription digital therapeutic for the treatment of NVD symptoms as an adjunct to clinician managed outpatient care for adults with MDD, ages 22 years and older, who are also taking an antidepressant. So intended to help kind of augment that and reduce MDD symptoms. And it has 3 components and is delivered over a course of 6 weeks. So the first component is what we call an EFMT exercise. This is, I think, the most novel component of Rejoyn. So it's the emotional faces memory task. And I'll show you, I'll break it down a little bit, but effectively this is a neurocognitive task that is intended to target key regions of the brain that have been consistently implicated in depression symptoms. And so these are exercises that are done 3 times a week over that 6-week period, takes between 11 and 26 minutes to complete. And those are interspersed with CBT-based lessons. So a lot of the things that you would expect, right, for depression, emotion regulation, helping patients become more mindful of their emotions, how they experience them and act on them, behavioral activation, trying to increase those goal-directed behaviors and stimulate positive interactions with the environment, and then cognitive restructuring, identifying challenging unhelpful thoughts. And then the third component is support, right? Because we know from the vast literature on digital treatments, engagement is a huge problem, steep drop off consistently, right? Even with the best tools out there. So having personalized messages that help reinforce the skills that people are learning and keep people sticking with the treatment program. And to get more into this core mechanism, this emotional faces memory task. So why this is thought to work is that we know in patients with depression, right, we see kind of dysregulation in brain regions associated with emotional processing, and then your ability to control those emotions. So amygdala is hyperactive. Obviously, that leads to kind of this intense bottom-up processing of negative emotions. Negative emotions feel more intense, or we feel negative emotions in response to something ambiguous or neutral. And then there's also, it's like this double whammy of your prefrontal cortex, which is kind of allowing for that top-down cognitive control and working memory, is not working as well, which makes it even harder to regulate emotions. And so the idea is it's this kind of pathway, this dysregulation, that leads people with depression to ruminate, to have difficulty breaking away from those really sticky negative thoughts, and to perseverate on negative thoughts and emotions. And so the core component of Rejoyn is this emotional faces memory task that's intended to activate both of those regions of the brain at the same time. So people are doing this task that involves seeing emotional faces. So you can see obviously some samples here, right? And what they have to do is actually say, okay, does this emotion match the emotion 2 images before? So they're having to really recruit that dorsolateral prefrontal cortex to exercise kind of top-down control in order to successfully do this working memory task. And so the idea is that we're trying to strengthen this really specific pathway of the brain, help people break away from some of those ruminative patterns. And so in terms of the actual trial, so again, this is what was presented to FDA, right, in terms of evidence supporting, is this an effective, or can this be an effective treatment for depression? It was called the Mirai trial. It was a randomized double-blind control trial looking at effectiveness and safety of Rejoyn. The trial lasted 13 weeks. So there was this initial screening period. There was a 6-week treatment period, and you can see the 2 arms there, and then an extension period. And people were randomized to either get Rejoyn, the digital therapeutic, alongside their antidepressant, or a sham app. And so Rejoyn had the components I mentioned earlier, the sham app. And so we wanted to test it against a really solid comparison, right? Not just kind of like a wait list or treatment as usual, and say, okay, what's a task that would be very similar to what we're doing, but without that emotional component? So it was basically a working memory task with just shapes instead of the emotional faces. And people in both groups had the sort of personalized reminders, text messages throughout. You can see, one thing that I think comes up a lot that is a challenge is with demographic biases in digital health trials. So pretty predominantly female, predominantly white sample. So something to kind of a caveat to keep in mind as we're going through these results. And then the thing that we were looking at is, okay, over 6 weeks, do we see a change in the MADRS score? So the clinician rated measure of depression symptoms. And before I show you the results, I'll just say that we look at the data in a couple of different ways with a couple of different analysis sets. So we have our intent to treat population. This is everyone who was randomized to one of the two groups. We have our modified intent to treat population. You can see it's a little bit more stringent of people who were randomized, did at least one treatment session, and had at least 2 assessments, right? So we had a pre-post on their depression symptoms. And then in testing whether this is safe, we included anyone with at least one treatment session. And so here's what we found. So you can see red is the Rejoyn group, gray is the sham group. Across both the intent to treat population and the modified intent to treat population, we see patients are coming in with moderate severity of baseline symptoms across both groups. So I'll start there. But we see about an almost 9-point change on the MADRS in the Rejoyn group in both of these populations. In the intent to treat population, it was a significantly greater decrease in depression symptoms than with the sham app. And in the modified intent to treat group, a similar magnitude differences, but the difference did not reach statistical significance according to our pre-specified threshold of P of 0.049. We know that clinicians don't actually think about the MADRS in real life practice, right? We're used to seeing PHQ-9s and GAD-7, so we also look at those endpoints. And here we're looking at change in PHQ scores over time. So you can see that across both of these subsets of our sample, in the Rejoyn group in red, we saw a significantly greater decrease in depression symptoms on the PHQ-9, regardless of which analysis that we looked at. And it represented, I think, not just a statistically significant difference, but also a clinically meaningful one of this difference involves moving from a moderately severe level of depression at baseline into the mild category. And a good thing with digital therapeutics is they're largely safe, right? So as you would expect, there are not a lot of side effects with a digital therapeutic like Rejoyn. No one discontinued the trial due to treatment emergent adverse events. There was one serious event during the trial, but it was evaluated as not to be related to Rejoyn. And things that come up more commonly are things like headache, right? Probably from kind of looking at a screen. So in terms of where we are now, Rejoyn is out there. It's a digital therapeutic that is being prescribed by providers, which is exciting. It was cleared last year, so it's still relatively new. And right now, one way of prescribing Rejoyn is actually directly through your EMR to Carry RX, which is our pharmacy. And the other, for non-prescribers like myself, it would be, if there's a patient who are like, this might be a beneficial adjunct, but you can refer them to a virtual consultation with a platform called Wheel Health. And there's built-in patient support throughout, right? So that's, again, very attuned to this issue with digital of people want that human connection, that contact, feeling like someone's checking in on them and their treatment. So there is end-to-end nurse support throughout the 6 weeks of treatment. There's a solid support team. And then, of course, the text messages and app notifications as well. So, I know we didn't explicitly talk through codes, and I imagine there will be some questions that I'm happy to chat through about those too, but something that we're always thinking about as we're so new is like, how do we make these treatments accessible, feasible, like usable by clinicians working in collaborative care systems, working in primary care, other outpatient settings where we know there's a lot of mental health demand and long wait lists for behavioral health providers. So where does something like this fit in? So we'll be curious to learn from your expertise, obviously as folks working in those spaces, about how we might be able to help solve some of those, or not solve, but help move people closer towards closing some of those access gaps. So thanks so much again for having me, and happy to take questions.
Thanks so much, Caitlin. Caitlin, you brought the research, huh? Heavy on it. I like it though.
Yeah, I know. We always we're, we're heavy on the data always, so hopefully it was not too dry.
No, 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 no. It's good. It's good to see. I was going to say I hear. I see some head nods. Okay, well, lots of information to digest from Ethan and Caitlin. Opening up the floor either via the chat, or you can feel free. We're a really informal group, so you can also feel free to come off of mute and ask your questions directly to Ethan or Caitlin that you may have about what they're doing, what they're working on, how we can incorporate it, any of those questions that you might have for them from a nuance perspective. Oh, we're going to be a quiet group today.
I have a question for Caitlin.
Yeah, go ahead, John.
In the study that you did, what were the exclusion criteria for getting into the study?
It's a great question. Here, let me see. I think I may have a slide for that. So I don't have a slide for specifically that speaks to that, but I can just share. So exclusion criteria, patients could not have failed a course of CBT before. Patients there's a long list, I'm not going to remember all of them, but had to have MDD as their primary diagnosis. They could have comorbid diagnoses, right? Obviously, we understand that most of the time patients are coming in with multiple diagnoses. It just had to be depression as primary. If they were taking certain classes of medications like an antipsychotic or other kind of augmentation medications for depression, those were excluded. I think suicidality beyond ideation. There were a few, they had to be stable on their meds. So probably a few other things that I'm not thinking of, but those are the bigger ones.
Thanks
Hey,
for your
Caitlin.
research, Ethan. Oh, go ahead,
Yeah,
Bob. Sorry.
is that okay? Can I jump on? All right, sorry.
Absolutely.
So I got to go to cost, Caitlin. Who pays for your service? So if somebody qualifies, and now you're in mainstream. Who pays for it? Is it covered by third parties? Is it covered by Medicare?
So that's like I mean, I'm really glad you asked that, Bob. Such a good and important question. And so historically, reimbursement for digital therapeutics has not been good. It's been a huge challenge. There's not been kind of the infrastructure. I would say the policy landscape has lagged behind the science, and obviously it takes a long time for that to shift. So
Yeah.
as we discussed before, I can briefly share my screen. There are codes that, and I may be able to send this out if this would be useful, Monica and team, but
Yeah.
there are codes that can be leveraged now, right? New codes focused on digital mental health treatments, right? So there's a code for that initial like setup and onboarding by the provider, kind of treatment management, initial minutes of treatment management that can occur monthly, and then the sort of additional time, right, like associated with services relating to the digital therapeutics. So this is, I would say, progress in the right direction. I don't know off the top of my head what coverage and kind of reimbursement rates look like. I know that these are being implemented and used, but this is all quite new. So I would definitely say, like, if folks are interested and end up ordering this for a patient, we welcome any feedback on some of any implementation challenges or like hiccups that come up, right? Like we're always trying to better understand what those real world barriers are. And we know that cost is always going to be one of them.
Yeah, I'm just wondering if can we also, just to piggyback on that, can you also build that on top of CoCM?
I believe so, but I don't know off the top of my head. It's not my kind of area of expertise, but that's something I can definitely look into and report back.
No, that's Monica's homework. She'll find
Yeah.
out for me.
Well, actually, I was
I mean, please let me know, Monica.
Yeah.
Well,
I should
Caitlin,
know.
just as you mentioned not knowing the reimbursement rates, I was like, oh, I should have pulled up that document. I know those reimbursement rates.
Oh, great.
And so I
Yeah.
do have that information. So yes, they can be used. Of course, you can't do double dipping, like we always talk about that. So the time you're using to have conversation with the patient around, their digital therapeutic and what's come up and all of that cannot be used as your time for collaborative care. So the minutes times from that standpoint, you can't double dip those. But there are some practices that are doing both, that are using digital therapeutics. They're also providing collaborative care services. So that does exist and happen.
Cool.
And I
Thank
can
you.
make sure to grab that information, and when we post, we'll post it on Basecamp.
Cool. Thank you.
Absolutely. Great question, Bob.
Monica, I had a question for Ethan, if I could.
Yeah.
Ethan, given that you guys are working with the Medicare population, have you struggled at all with the use of technology with the populations you're working with?
Yeah, great question, Ben. Absolutely. That was probably the hardest, that was probably the biggest struggle early on. We put a lot of time into making it as easy and simple as possible. Rolling out an app to an elderly population who don't know how to utilize their smartphone properly, don't know how to receive notifications, where to find their text messages. It could be a struggle. But we've tried our best to simplify it with just the push of a button, with just an easy text that they could follow along and click a link without having to download anything. At the same time, our niche has really been in the home care world, the home care services. And by working alongside home care agencies and utilizing the home health aides that are there on site, it's made things a lot easier. So finding that patient champion, finding that caregiver who can assist really helps as well. We also have nurses who are out in the field. We have multiple nurses who are there. So if there's somebody struggling, we'll always find a way to resolve that issue.
Caitlin, I have a question for you, if I may. Given the structures of the brain that you identified, my first thought was, boy, are they looking at anxiety and ADHD? Is that in your future?
Love that question, Ben. Yeah, thanks so much. I firmly believe, right, and there's research showing this, that those processes that we talked about that we think underlie that tendency to ruminate and that cognitive control over emotions, leading to perseverative thinking, that's transdiagnostic. It's not unique to rumination and depression. It seems to underlie worry and generalized anxiety, or like the post-event processing that happens in social anxiety. So we don't have data on this yet, but something we're actively exploring is thinking about what would it look like to adapt this, or how much adaptation would be needed, and would we see similar impacts, particularly in generalized anxiety disorder.
Thank you.
Thanks for your questions, Ben. Okay. If there's nothing else burning, although I know some people are gonna still be taking stuff in. And so if you do need to reach out to Ethan or Caitlin, the recording from this will be uploaded. I think typically Hannah has it up pretty quick, but let's say the next week. You'll be able to grab their information. If you have additional questions or things of that nature in reference to the information shared. Ben and I have gotten emails while we've been sitting here about other topic areas that some of you are wanting to hear more about. So please keep those coming. Otherwise, you have transition time to use the restroom, hydrate, grab a snack, all of the things. Um, and we hope you have a good rock star rest of your day.
Thank you so much again, Monica and everyone. Appreciate it.
Yeah, thank you. Thank you,
Thank
Caitlin and
you.
Ethan.
Bye.
Everyone.
Bye-bye.